Our speaker today, we welcome Dr. Chandra Vethody. She completed her medical training at the University of Louisville for a residency in internal medicine before going on to do a fellowship in allergy and immunology, where she trained at Vanderbilt University. She joined our faculty in August of last year. She has many interests in the field of allergy and immunology, and today she will be talking to us about drug allergies. So I hand it over to Dr. Vethody.
Hello, everyone. Thank you for joining me during your lunch hour. We are going to begin with the learning objectives of this talk, starting with the epidemiology of drug allergies, discussing the public health burden of the same. Oh, I'm sorry, I did not share my screen. Give me 1 second. Okay, can everyone see it now?
Yes.
Okay, thank you. Okay, so we're going to start with the epidemiology of drug allergies, and then we're going to discuss the public health burden of the same. We're going to discuss some newer definitions of adverse drug reactions that has come out at least in the last 5 years or so. We're going to talk about the management pertaining to antibiotic drug allergies, because this is what I most commonly see in the pediatric population. And then hot topics for this talk, which I know a lot of you are here for, are the COVID vaccine allergic reactions, what we know now, and how to differentiate between fact and fiction. Throughout this talk, before I begin, you will notice that I pulled out data from both the adult and the pediatric population. And that is because the general principle and the concept is the same in terms of management. Allergy and immunology really is a combined field, which is why me as an internist can see patients in the pediatric population and pediatricians can see adult patients. It's just the nature of the field. Okay, so with the epidemiology of drug allergies, as you all know, pediatric drug allergy is a huge public health burden in our society. It can be estimated at least 5 million children in the country are labeled with penicillin allergy specifically. As more and more research comes out, especially when patients present with rashes, we know that it could be the infection, it could be an interaction between the drug and the infection. It is very rarely just the drug, and it's usually not reflective of true drug hypersensitivities. Antibiotic label allergies are often acquired because they're reported by parents and they're never clarified, they never undergo drug allergy evaluation, and these labels stay in their chart through the adolescent years, even into their adult years. Antibiotic label allergies are common, especially penicillin allergies. It can be estimated that penicillin allergies can be seen in up to 15% of most populations. Cephalosporin allergy, 1 to 2% of most populations. Drug allergies are generally more common in females than in males. Cephalosporin allergies are seen in kids who tend to develop or who tend to be exposed to a lot of antibiotics, like cystic fibrosis patients. Bactrim and sulfa allergies seen in about 5% of the population. Here it's seen in patients with HIV, immune deficient, oncology patients, and transplant patients. But why do we care about drug allergy labels in patients' chart? In a recent study, it was shown that 75% of penicillin drug allergy labels were acquired in childhood by the age of 3. Most labels are inaccurate. When you see a drug allergy label in a patient's chart, it could be reflective of side effects, intolerances, family history, and a lot of the time they are not true drug hypersensitivities. It can be estimated that 15% of adults have penicillin allergy labels, and less than 5% are actually allergic. And even true allergy, and even if they had true anaphylaxis, that tends to fade over time, and more data on this in subsequent slides. The label can become a greater liability than the risk of a reaction. So what happens when a patient has a penicillin allergy label or any other drug allergy label, and that is the drug of choice? There's a pressure prescribing of second and third line antimicrobials, right? And there is this increase in appropriate antibiotic selection, increased mortality risks from cancer and infection treatment. Usually it delays the onset of appropriate antibiotic therapy, increased treatment failures, surgical infections. Huge problem in this population is multi-drug resistant infections. All of the above leads to higher healthcare costs. When you remove the antibiotic allergy labels or any drug allergy label at an early age, it overall reduces expenses, patients are safer, and it just generally avoids bad outcomes. So less treatment failures, multi-drug resistant infections, surgical infections, etc. When children are tested and undergo challenging or oral drug challenges, it is seen that at least 90% or more are able to tolerate the antibiotic. Unfortunately, even in my clinic, after I go through a whole drug allergy evaluation, and give the patient drug and prove the drug and prove that they're not allergic, there is still a lot of resistance among families, among patients themselves, even amongst providers. But what about when the drug the patient reacted to was previously a drug of choice, and what if we're out of other options? This is the most common consult that I see in the Children's Hospital, especially pertaining to whenever they have drug allergies. And it's usually when the team has exhausted other options and there are undesirable side effects from other drugs. Do I even get consulted? My hope as allergists, as an allergist and allergists in general, is that we delabel these kids at an early age so it does not come to that point. What if a patient has a sulfa allergy and needs immune deficiency prophylaxis, or a transplant patient? Penicillin allergy in a patient with MSSA bacteremia, group B strep. What if by not giving the drug, we're actually providing them with an inferior outcome? We're going to go over the newer definitions now of adverse drug reactions. We have moved away from the older definitions. As you may have learned in medical school, we initially used to classify adverse drug reactions as type A and type B, predictable, unpredictable. As our mechanistic understanding of adverse drug reactions improve, we now classify them as on-target and off-target adverse drug reactions. On-target are basically predictable based on drug action. C. diff colitis is a classic example. So it's basically the augmentation of known pharmacological and therapeutic actions of the drug. And off-target adverse drug reactions are non-immunologically mediated and immunologically mediated. They're broadly defined. And then when there is a interaction of the drug with a non-immune cell receptor, classically aminoglycoside-induced ATN, causing apoptosis via the mitochondrial pathway of apoptosis, that's a classic example of non-receptor interaction. Immune receptor interaction. The classic example is interaction with this receptor called MRGPRX2, which you all may not be familiar with, but it's becoming more famous in the allergy world. You all may be familiar with vancomycin, the red man syndrome caused by vancomycin, radio contrast media, they're like the allergic reactions caused by radio contrast media. It's because of interaction. Those kind of reactions take place because of the drug interacting with this receptor. It basically causes mast cell degranulation and mimics allergic reactions independent of IgE. So another drug that comes under this category that you may not be familiar with is fluoroquinolones as well. So if someone comes in with a history of an allergic reaction to fluoroquinolone and they test negative to fluoroquinolone, I tell them to go ahead and pre-treat them with antihistamines and steroids the same way that we would do with vancomycin or radiocontrast media. And then the other huge category under the off-target adverse drug reactions are your immunological mediated hypersensitivity reactions. And this is your classic type 1 through type 4 hypersensitivity reactions. But here they've broadly defined it into antibody mediated and pure T cell mediated. Antibodies type 1 to type 3, so serum sickness, type 1 hypersensitivities come under this. And then pure T cell mediated, which is your DRESS, SJS, TEN, and things like that. When I talk about the management, I'm going to concentrate on the antibody mediated reactions, particularly type 1 hypersensitivities, because this is the most common cause of referral for me. And if I talk about management of T cell mediated reactions, it'll be another 30 minutes. So this is a chart that I show families that are resistant to do testing or delabeling, resistant to do oral challenges. I basically show them this chart and I say, so this is the x-axis that shows the time between the reaction and the testing. This the y-axis shows the probability of positive skin testing, penicillin skin testing. And what this chart shows is that even if you had a true IgE mediated process and you tested positive to penicillin, chances are as the years go by, you've essentially grown out of it. It actually, the skin test positivity actually decreases by 10% per year. So chances are that when you're a 10-year-old and if you've had your reaction and it was a rash at 1 year of age, you've essentially grown out of your allergy. And that seems to reassure them. Whenever I get a referral for penicillin allergy or any kind of drug allergy, what we as allergists are trying to do is to risk stratify. Basically, what I try to do is make sure that it is not anything in this highest risk category. SJS, TEN, DRESS, AGEP, which is acute generalized erythematous pustulosis, even serum sickness. Those are high-risk reactions that cannot undergo testing, usually lifelong. We cannot give them the drug again. For high-risk reactions are usually consistent with anaphylaxis, regardless of the time since the reaction. If I think it's consistent with anaphylaxis, that's a high-risk reaction. What I do want you all to pay attention to as pediatricians is this low-risk history. Majority of the time in the pediatric population, it is always some rash that started several days after starting an antibiotic that lasted for several days, even after switching the antibiotic. And that's the most common reaction that I get. And that's always going to be a low risk history. For kids, even urticaria lasting for several days, in my mind, that is infectious and that's a low risk history. The other lowest history that you're looking for is family history, just GI side effects, known tolerance of the penicillin since the original reaction. So I can't tell you the number of times I've just gone through the med history of an adolescent or a teenage patient, and they've received Augmentin. And in families' minds, somehow Augmentin is not a penicillin and they just didn't know that they were taking penicillin the whole time. So that's a quick and easy way. You can even, defer referring to an allergist to get this addressed. a lot of data to bypass skin testing in penicillin allergies in children, in teenagers, even in adults. As you can see, all of these studies, and this list is not exhaustive, all of these studies bypass skin testing and what they did in different settings, outpatient, inpatient. I think the second one was in the emergency room. They basically got a good history, made sure they had a low risk history, bypassed the skin testing and challenged these kids anyways. And as you can see, a good amount of them passed, greater than 90% in every study. Again, this list is not exhaustive. This study was interesting. 3 patients actually tested positive on prick testing. They went ahead and did intradermal testing, which we will talk about. The intradermal testing was negative and they had a low risk history. So they went ahead and challenged them anyways, and 100% of these patients passed the challenge. How do we test these drug allergies? Whenever you refer a patient for penicillin skin testing or any other drug allergy testing, we are only testing for an IgE-mediated process. You can do non-immediate hypersensitivity skin testing that is for T-cell mediated reactions, usually not in the community. It's usually in like big drug allergy academic centers. Vanderbilt is one of them, Mass Gen, Boston Children's is another one. So it's definitely out there and you can do them. It's just largely research based at this point. This is obviously an adult arm, but this is exactly what we do in kids. Usually the biggest question that I get is, what is the age limit in testing for kids? There is none. I've tested even in 4-month-old, 6-month-old. They just fall asleep during the procedure. It's usually very well tolerated. Again, if I could get away with not doing testing and just doing a challenge in those kids, that's what I usually do. A few caveats when it comes to beta-lactam allergy. A tolerance of a cephalosporin allergy does not rule out a penicillin allergy, and the reverse is also true. A penicillin allergy does not rule out a cephalosporin allergy. It was previously thought that the beta-lactam structure itself caused these cross-reactivities, but now as more and more research comes out, it is actually the side chain R1, which causes the cross-reactivity between beta-lactams, which I'll show you a diagram in subsequent slides. If you want to know the true cross-reactivity between beta-lactams, you should consult an allergist. Specific patients are excluded from skin testing. Any T-cell mediated process, SJS, TEN, DRESS. I cannot test for serum sickness either. A single dose challenge does not rule out the risk of a delayed reaction. So this is what I tell all patients whenever they come to me for penicillin skin testing or an oral challenge. Are they going to get a non-specific rash tomorrow? I don't know. 2 to 5% of the population, of the general population, will develop a benign rash with penicillin 24 to 48 hours later, and they could develop that. But what I try to stress during the clinic visit is that the benefits of getting this label removed always outweighs the risk of you having a rash that you can treat through with antihistamines. So what are the cross-reactivity of antibiotics? So like I said, it was previously thought that they all shared this 4-membered ring, and that was the reason for the cross-reactivity. But now we know that it is actually the side chains that causes cross-reactivity between penicillins and cephalosporins and beta-lactams in general. So you all as pediatricians, it may be of interest to you to know that if you have a kid, have a patient that you are truly suspecting anaphylaxis to penicillin, which is rare in general, but if you're truly suspecting that, something that you may want to tell them to avoid in the meantime while you refer to an allergist, is Keflex, which is commonly prescribed in the pediatric population. I haven't seen any of these other drugs being prescribed in the pediatric population. And then same with cephalosporins. Whenever I get a kid, mostly it's the cystic fibrosis kids that have cephalosporin allergies. And it takes some time for me to get the drug and test and delabel cephalosporins in general, because it's not readily available in our clinic. If they reacted to, say, ceftriaxone, I just tell them to avoid these 3 drugs. I do not tell them to avoid Keflex. So it's really not a whole class thing. It's really certain drugs in the penicillin family or certain drugs in the cephalosporin family. Quick recap on this section before we go to the other section. If a patient comes to me with drug allergies, the one thing that I do is, and the only thing that I do really, is risk stratify. Look at the medications, the timing of the symptoms. If they had it right after their first dose within 30 minutes, that's more consistent with anaphylaxis. If they have a low risk history, I go ahead, if I can get away with it, I go ahead and just challenge them in clinic the same day. If they have a high risk history that is consistent with anaphylaxis, regardless of the time since anaphylaxis, since that history, I skin test them. I usually do prick and intradermal for high risk testing, for high risk intradermal, for high risk challenges or high risk histories. And if they are positive, I tell them to avoid the antibiotic and structurally related drugs. If they are positive and they absolutely need the drug and they are, then there is no other alternative medications. This is when we actually do desensitizations as allergists. So they have to have a high risk history, plus they have to have positive skin testing, or may not even need positive skin testing, especially if they're admitted in the hospital. We may not be able to do skin testing, but if they have a high risk history and they need the drug, we can absolutely do desensitizations to almost any drug these days. And if they are negative, I go ahead and challenge them and delabel them. Testing is not recommended for T-cell mediated reactions. I just tell them to avoid the antibiotic or the drug or structurally related drugs as well. Okay, so now we come to the next section, which I know all of you are here, a lot of you are here for. This is mostly, obviously, I'm going to talk about adult data because this is where predominantly it's been reported, and it wasn't really reported in the clinical trial as much. It was only when it was given to healthcare providers, especially in the community, that this it was all over the news when it happened in the UK, and then it was all over the news in the US as well. And it was during this time that I was getting a lot of questions from families, because it was reported in the news that these patients who had these allergic reactions tended to have more allergies in general. So all of them, had an EpiPen, had allergic rhinitis or food allergies. And I see a lot of that patient population, obviously. So hopefully this data is enough for you to at least advise your patients and really reassure them. So the two vaccines that I'm going to talk about are Pfizer and Moderna. We just don't have enough data for Johnson & Johnson yet. As you all know, they are both mRNA vaccines, and the antibodies that are produced are viral spike protein antibodies. And I've highlighted, so basically these are the active and inactive constituents, and I've highlighted the potential culprit, which we will talk about. So why is this important? Vaccine allergic reactions can cause vaccine hesitancy. I've definitely seen it in my own practice. Adverse drug reactions can cause vaccine hesitancy. We need to get over this pandemic. We are all exhausted. You are exhausted. I'm exhausted. Our patients are exhausted. And kids are a huge part of the general population. If less kids get vaccinated, we are less likely to reach herd immunity. So a few things about anaphylactic reactions to SARS-CoV-2 vaccines. Mostly all IgE-mediated reactions require prior exposure. They require you to be sensitized, and it's almost always to a protein. The reactions to SARS-CoV-2 vaccines is interesting because the COVID vaccine does not contain a protein, and all of these reactions have been reported after the first dose. This is the initial patient population that was reported to the VAERS system. You all are probably familiar with the VAERS system, which is a vaccine adverse events reporting system. So basically, if a patient has any kind of adverse event, you can report it to this database. And if you want to search it, you can actually pull that data out of that database. So this is out of that database, and this is the initial patient population that had allergic reactions. And as you can see, majority of them were female. A lot of them had history of some kind of allergy. And then all of them had this, all of them developed this allergic reaction within 15 minutes, which is where this magic number 15-minute wait comes from. All of them received epi. And importantly, all of them recovered. The Brighton level scoring system is a scoring system for anaphylaxis, and it basically tells you if it meets criteria or clinical criteria for anaphylaxis or not. 1 and 2 are pretty good indicators for anaphylaxis. 3 or 4 are not. So all of them met good criteria for anaphylaxis. This is the largest study. This was done actually by the fellows in Boston Children's and Mass Gen. They prospectively looked at 64,900 healthcare employees, healthcare workers that actually received Pfizer or Moderna. And what they found was about 1,300 self-reported allergic reactions. But out of the 1,300, the ones that actually met criteria for anaphylaxis were very few. And this is different criteria for anaphylaxis as well. Very few of them actually met criteria. Only 16 out of that 1,300 met criteria. Reactions were self-reported allergic reactions, was slightly more with Moderna than they were with Pfizer. That was statistically significant. Similar to the CDC data or the VAERS reporting system data, majority of them were females. A lot of them had prior allergic reactions or anaphylaxis. A lot of them, actually all of them, reacted within 30 minutes. And this is, again, where that recommendation of patients who have history of allergies are required to wait 30 minutes. That's where that came, the 30-minute mark came from. Interestingly, one patient ended up in the ICU, but all of them recovered. And only one patient, and the fellows were actually good about getting tryptases, which, as you all know, are markers of mast cell degranulation. So the earlier you get it, the more it is elevated, it is more consistent with anaphylaxis. So only one patient out of the 16 had an elevated tryptase. So a few take-home points, and this is the study that I always go back to when I try to reassure my atopic patients who will be eligible to get these vaccines in the future pretty soon, at least 12 and above. 64,000 employees receiving Pfizer and Moderna after the first dose. And again, that study was done only looking at the first dose because this is when most of the allergic reactions occurred. 98% of them had no symptoms. 2% had some allergy symptoms like itching, rash, hives, swelling. Anaphylaxis only occurred in 2.47 out of 10K vaccinations. It was slightly more with Moderna than it was with Pfizer. Only one patient had elevated tryptase, and most importantly, all of them recovered. So why were there so many self-reported allergic reactions? And this is what I always have to do, even in my oral food challenges and my drug allergy challenges, is I have to think about a broad differential of what other than anaphylaxis, what else could it be? Most commonly, especially for my injection challenges, like I had an insulin challenge the other day. And that kid, she was 13, and she definitely had a vasovagal reaction that mom was convinced that it was anaphylaxis, but I got a tryptase and it was negative, and I was able to convince mom that this was just a vasovagal response. So a lot of vasovagal reactions in injection challenges. Vocal cord spasm is another common mimicker, and then anxiety. You're essentially giving something giving something to the patient, and the patient thinks that they may be allergic to. So nerves play an important role in mimicking anaphylaxis as well. Changes that you may wish to make in your practice. I have no idea how it's going to be in the pediatric population. They are saying that it could be a yearly vaccine. Or it could be done, when it is implemented in kids or given to kids, it could be done in primary care offices as well. So you might want to recognize anaphylaxis when it does happen, but also know that there's a broad differential. Carefully record vital signs, physical exam findings, skin findings. Please take pictures when there are rashes. We love pictures as allergists. Obtain tryptase within 90 minutes, but you can even do it up to 4 hours after the onset of a reaction. Review the timing of immediate reactions. So if the earlier the reaction occurs, the more consistent it is with anaphylaxis. If the reaction occurred after the first dose, weigh risk of receiving the second dose versus being inadequately vaccinated. Refrain from calling patients allergic, and please refer to an allergist to help facilitate the safe administration of this vaccine. And most importantly, and this is the huge limitation that we have as allergists, is getting the actual vaccine, which is scarce in the first place, to test to test and see if it was the actual vaccine. So these are the active and inactive ingredients in both Pfizer and Moderna. What I want you to pay attention to is polyethylene glycol. It is a rare allergy, but it does happen. Now, what is polyethylene glycol? It's Miralax. You guys prescribe it all the time. And when I evaluate a patient for polyethylene glycol anaphylaxis, which is present in a lot of injectables, including vaccines, I test them to Miralax. Few things about polyethylene glycol allergy. PEG allergy is rare. It's reported in case reports in both adult and the pediatric population. It's seen in a wide variety of medications, bowel prep, cosmetics, eye drops. It's also seen in like gel, ultrasound gel. Such an ingredient could potentially explain how a patient is sensitized prior to PEG, but the amount of PEG that is contained in Pfizer or Moderna is actually very little compared to the ones that we commonly see with injectables. So in adults, we usually see dipomedrol as a potential culprit causing an allergic reaction, and we test them to PEG, but dipomedrol has 21.9 milligrams and Pfizer only has 0.05 milligrams of PEG. To date, importantly, there has been no skin test or IgE positive to the vaccine or PEG that has been published. There is a lot of speculation among allergists, and we're trying our hardest to get these patients into our clinic and test them. But the limitation is obtaining the vaccine itself to test. So it hasn't been reported. In fact, I was talking to my colleague who is currently in University of Washington, who happened to have the lady in Alaska, who reacted to Pfizer, who ended up in the ICU in Alaska. She actually tested positive to PEG, and she actually had anaphylaxis to Miralax, but they couldn't test to the vaccine because it just wasn't available in Washington at that time. So we could not get that particular paper published. But more to come on this. So I did want you to be familiar as to how PEG anaphylaxis or PEG allergy presents. It's a very peculiar allergy because it gets worse on repeat exposure. So this is a case that I was involved in fellowship. 3 years prior, this patient, he was like a paint department manager. 3 years prior, he had a depot shot in his knee. All he developed was like lightheadedness and throat tightness, which improved with antihistamines. On more and more exposure, especially with paints containing PEG, he had pruritic swollen hands. Then he developed anaphylaxis during his bowel prep on consuming Golightly during his colonoscopy. That reaction was severe enough to require epi. And then 1 month prior to referral to our clinic, he had a myocardial perfusion scan that had a PEG-related product. And within minutes, he had the most severe reaction, ended up on an epi drip in the ICU. So as you get more and more exposed, they tend to get worse reactions. And this is what we do for PEG testing. This is what we did for him. For kids, I usually just do the different concentrations of PEG because it's only a prick. I tend to avoid doing intradermals unless I absolutely have to in kids. And if they reacted to some kind of steroid or injectable, I would test them to that as well to kind of prove that it's the PEG within the injectable that's causing the allergic reaction. A few differences between PEG and SARS-CoV-2 vaccine anaphylaxis. Both of them are rare. PEG is usually more seen in males than it is in females, where SARS-CoV-2 vaccine anaphylaxis is more seen in females than males. Again, worsens on repeat exposure. They tend to anaphylax with intradermal skin testing for PEG. In fact, the previous patient actually did go into anaphylaxis and we had to send him to the ED. Patients who have PEG anaphylaxis don't tend to be allergic patients, whereas in patients with COVID vaccine anaphylaxis, as you've seen in previous slides, they tend to have a history of A to B. But there's a lot, again, that we just don't know. I did want to show you this chart because as pediatricians, you probably have already given vaccines to patients with PEG in it. So polysorbates are actually a monomer of PEG. And as you can see, polysorbates are in a whole variety of childhood vaccines. So chances are your patients have been exposed to it already. And then as you can see, I've highlighted PEG or polysorbate is present in all of the available SARS-CoV-2 vaccines, including Johnson & Johnson as well. Like I said before, the vaccine testing limitations is actually obtaining the vaccine. We don't know the stability of the vaccine, so ideally we would like to have it within 6 hours of reconstitution to test it. But if you could, if you as primary care providers once you do that referral, if you could keep the vaccine for us, it wouldn't even matter the time. As long as we have the vaccine, it will be very useful to actually to allergists in general. What is the alternative to testing? If the patient doesn't want to be tested, we don't have the vaccine, you could do the SARS-CoV-2 IgG antibody after the first dose. If titers are sufficiently positive, you may want to withhold the second dose. However, we already know that the second dose, getting the second dose is obviously more effective than the first dose, and there's not enough data to show that a single dose provides the same level of level of protection or duration of protection of disease. So administering the second dose once they've had an allergic reaction to the first dose, obviously there's a shared decision making with the patient and the family. You have to weigh the risk of having a vaccine reaction to being inadequately vaccinated to COVID-19. You could also delay the second dose until new vaccines become available, especially Johnson & Johnson, obviously after we're done with this pause. In fact, the lady in Alaska, against medical advice, went ahead and got Johnson & Johnson and did fine because she was very determined to get the vaccine in general. These are the current recommendations by CDC. I'm sure you all are aware. So if patients have allergies in general that are not to injectables, not to things that contain PEG or polysorbate in it, a 30-minute observation period is completely reasonable. If a patient has any immediate reaction to injectables, again, that do not contain polysorbate or not SARS-CoV-2 vaccines, that's not a contraindication. You can still give it to them, but you would need a 30-minute observation period versus the initial 15-minute observation period. If a patient has a severe allergic reaction to COVID-19 vaccines or its components, specifically if they have a history of allergic reactions to polyethylene glycol or its monomers like polysorbate, do not vaccinate. Defer calling them allergic to the vaccines. Please consider a referral to an allergist. This is another delayed reaction that I do want you all to be aware of because it is relatively common. I've even had some relatives develop this reaction after Moderna. So this patient in particular, which was reported by the Boston group, received Moderna 1 week ago, did well in the initial 15-minute observation period, but had arm pain, headaches in the first few days. It resolved, and then 1 week into the course developed a red swollen arm. And this is what it looked like. They did fine. 1 week later, had large local reactions. This was actually reported in the clinical trial. Patients with large local reactions it's not a contraindication to receive second doses. It was reported in the clinical trial, particularly after the first dose. It is currently unknown if the patients will develop a similar reaction after the second dose, but it does not predict anaphylaxis. It is safe to receive the second dose, preferably in the opposite arm. So more information to come on allergic reactions to Pfizer and Moderna in the next few months. Actually, we just got an email a couple of weeks ago saying that the NIAID, the National Institute of Allergy and Infectious Disease, are doing a new clinical trial looking at immediate allergic reactions to both Pfizer and Moderna vaccines. It's conducted among 35 academic drug allergy research centers across the United States. it will determine which patients are at increased risk for anaphylaxis, or if they are even at increased risk for anaphylaxis, and also determine genetic patterns and other factors that determine the risk of such reactions. So stay tuned on this. So hopefully there will be more data to come before to advise your patients before this is even rolled out to the pediatric population. And with that, I conclude my talk. Hopefully I've given you the tools of when to refer to an allergist, especially for your kids with lots of antibiotic allergies, and also given you the tools to advise your patients and address the problem of vaccine hesitancy that we see in our community.
All right, thank you for the talk. A couple questions. So do you, if a patient is in the hospital and they say they have a penicillin allergy, are you all testing them in the hospital?
No, we do not have the ability to test them in the hospital. The most common consult that I get is penicillin allergy in the hospital. And if they have a low risk history, I go ahead and just give them a dose of amoxicillin and watch them for a couple hours. And majority of them pass.
And would there be a role of desensitizing a patient in the hospital?
Only if they have a history of anaphylaxis. Like if I am really suspecting a severe immediate allergic reaction, do I even recommend desensitizations? Desensitization is just an induction of tolerance. You cannot remove the label after it's done. And the downside of that is if you take a break for 24 to 48 hours and not give the drug, and you have to give the drug again in the future, you have to go over through the entire procedure again.
Okay. And now that we're getting close to summer and tick season, can you comment about alpha-gal allergy?
Yes. Actually, I had a patient today with alpha-gal allergy. I am not seeing that at all, actually, in the Kentucky area, because I test for it all the time, thinking that it's here. I saw it a lot in Tennessee. Basically, it's a red meat allergy. It's a delayed, it's seen mostly in the southeastern parts of the United States where the Lone Star tick is present. A lot of the time, the tick, you don't even notice the tick. But patients will develop this delayed anaphylaxis with mammalian meat products. So beef, pork, lamb, things like that. And a lot of the time it goes missed, and it's kind of like an idiopathic thing no one can find the reason for the allergy because they don't think about the steak that they had for dinner, and they're waking up in the middle of the night with this allergic reaction. So it can be missed because it's a delay. The characteristic of it is that it's a delayed anaphylaxis and delayed urticaria, GI symptoms, and things like that. It was only discovered in like the last, I think it was discovered first in 2009. So there's a lot we just don't know about it. So there's a lab that you can order. If it's high, we tell them to avoid it and then avoid tick bites, because that's how it's the tick bite that sensitizes the patient and makes them allergic. So it's a very interesting allergy, but I'm yet to find a patient that has it here in Kentucky.
Interesting. And pediatric patients can get that also?
Oh, absolutely. Yes. Yes. As long as they're exposed to tick bites, which a lot of patients in Kentucky are. Yeah.
All right. Well, thank you, Dr. Vethody, and we appreciate the lecture today.